when you're talking and turn it off when you're not.
Silver button.
Oh, silver button makes it blue. Sorry.
That's right.
Just for
you.
people thinking you're talking about Tide Pods.
Okay, Marilyn, go ahead. Okay.
Francie Jermaine at El Paso County.
Jody Barker, Alzheimer's Association.
Wendy Farr, Colorado Springs.
Lucy Crandall, Colorado Springs. Jen Nemo, Community Health Partnership.
Carrie Schillinger, Area Agency on Aging.
Phyllis Huggins, Eastern El Paso.
Cynthia Aki, Colorado Springs.
Margaret Hunter, the Myron Stratton Home.
Joe Urban, Area Agency on Aging.
And for those in the audience, you start over here.
Joanne McCoy with the El Paso County Department of Human Services. Lisa Aldrich. Peggy Spalding, State Unit on Aging. Kathy Lowry, Television Coalition. Theo Beard, Television Coalition. Jack Ellis, Silver Key. Nicole Cato, CCS, also located. Trisha Funkin, nurse practitioner.
Jen, maybe you?
It's not even blue.
No, I'm thinking about electronics close to the microphone. I don't know.
There you go. See, it's your fault.
All right. Well, thank you very much. It's that noise kind of reminds us too. We should turn off the phones just to make sure the cell phones, just so they're off, no rings and stuff like that. So I think we've got the next thing on the agenda will be the consent items. We have the agenda before us here, and it has a number of different items. Are there any that needed to be adjusted or added to at this point? Any changes to the agenda? If not, all those in favor, let's just pass by consent for the agenda. All those in favor? Aye.
Aye.
Perfect. Okay. Minutes will be the next thing. And we had those, and they're attached, and this was way back in November 30th, a long time ago. It was a pretty full meeting, as most of us recall. And money was one of the highlights of it, or lowlights. Any changes or modifications to the minutes? Happy to, all those in favor of passing the minutes, say aye.
Aye.
Okay, so we've passed both the agenda and the minutes. Next thing on the agenda will be public comments. Are there comments that need to be made at this point that are not on the agenda? Well, hearing none, we're moving right on down then. So Wendy, I think you're next with the membership subcommittee.
So for those of you who are not aware, we have had someone who's had to take a step back because of other duties in her position for work. So Cheryl, right? I said that right. With the Department of El Paso County, has had a new role thrust upon her and some of her team, and so needing to take a step back on some of the other duties, and so she's had to resign, which is sad for us because having someone from the Department of Human Services here as a part of things has always been great, especially since Cheryl also served as the committee chair for the Technical Review Subcommittee. So she was sad, and we are sad also. However, we are very fortunate that she had a fabulous suggestion as a replacement to be here on the council with us. So I have had a nice long conversation with Joanne McCoy, as well as Carrie. We've received her application. We've gone through that, had various questions and answers to make sure she's comfortable with taking on this commitment. And I think, well, first of all, she actually serves as an ongoing adult Medicaid as a supervisor, in fact. So I think her expertise and knowledge as far as what Cheryl provided and now also what Joanne can provide is very important to what it is that we're trying to do as far as making sure that there's catch-all programs on behalf of those that we cannot serve, but we can get them something else. So I would like to propose that we have, and this is the part I don't do well, Carrie. I would like to propose that we have Joanne.
You might like to move.
Thank you. I'd like to move that we have Joanne McCoy as our newest addition as a council member.
Is there a second? Okay.
No
And there's a
second. Do you know Joanne?
And discussion. Any discussion on this? I think it's just throw out, it's really important, I think, to make sure that we have members representing all aspects of the community. And I think it really is important, as you pointed out, Wendy, that we have somebody from Department of Health. And it's unfortunate, I think, it's probably a good thing for Cheryl that she has, new opportunities at work and the rest of it. It's unfortunate for us because she was very, very strong member here as well.
Yes.
Any other thoughts or comments?
Welcome.
So we have a motion and a second to approve, add a new member, Ms. McCoy. All those in favor say aye.
Aye.
Opposed? Welcome aboard.
Yeah,
Come on up and take a seat.
Yeah, come sit by, yeah, go ahead. Yeah.
All right.
Adult ongoing, which is.
And I've talked with Carrie briefly, and we'll try to get together and recognize Cheryl's service as well. Just like it's important to welcome people, it's also important to make sure that everybody recognizes their accomplishments and their service. The next item will be special presentations. So Colorado Aging Network will be the first one. Should I turn this off? Leave it on.
It's on. Yeah, I don't think it makes any difference.
Okay, good morning, everyone. Let's see if voila. So good, Carrie. Thank you. My name is Peggy Spalding. Excuse me. I'm with the State Unit on Aging. And with the State Unit on Aging, I do grants and contracts. That's supposed to be my specialty. That's my title. So, but I do a dementia grant. I do a lifespan respite grant. When we had the Aging and Disability Resources for Colorado grant, I oversaw that. Now I oversee the ADRCs, and I partner with our Medicaid state office, who has the No Wrong Door grant. I also do the contracts for the area agencies on aging and anyone else that the State Unit on Aging contracts with. So that's kind of where my job title comes from. So let's see here.
And everything else that nobody else is around.
Yeah,
to do at the
that's
current
right.
time.
That's right. Anything else assigned, so I have a little of everything on my plate. So today, what I've been asked is to accomplish two goals. One is for you to obtain an understanding of the relationship and roles between the Administration for Community Living, the Older Americans Act, the State Unit on Aging, which is where I'm from, and the area agencies on aging. Our second goal today is to obtain an understanding of the eligibility requirements and the services that are available, which you're probably a little more familiar with. So let's start with the Administration for Community Living. They are housed in the Federal Department of Health and Human Services. Just like Colorado has Department of Human Services, Department of Healthcare Policy and Financing, the federal government has various departments. And they have a secretary of those departments, they have an assistant secretary, and that is where Administration for Community Living is housed. Community Living, the Administration for Community Living is fairly new. It was only created in 2012. And what they wanted to do is they wanted to bring aging and disability together. So when they did that, they added the Administration on Aging, they added the Health and Human Services Office on Disability, and then the Administration for Children and Families, Administration on Developmental Disabilities. So they started with those three departments, basically, put them into this Administration for Community Living. In 2013, they started adding additional ones, like some of you may know, State Health Insurance Assistive Programs, SHIP. They added that into the Administration for Community Living. They also added in their Traumatic Brain Injury Programs, TBI. So they're adding additional programs in there so that everybody works together, that we're avoiding those silos that we used to always have. That's the goal of this. ACL's mission is to maximize the independence, well-being, and health of older adults, people with disabilities, and their families and caregivers. ACL is a person-centered department. They believe in person-centered, which means every person has the right to make choices and to control the decisions in their lives. That's not up to a case manager to decide. It's up to those individuals. They believe that the preferences and needs of the older adults and people with disabilities who need assistance should be at the center of the system. That services and supports to enable them to live how they wish, the life that they want. And they also further believe that those needs and preferences should be defined by the individuals receiving those services and supports. So that's the Administration for Community Living. So we're going to start with a little funding flow chart. So we have the Administration for Community Living, and as I said, the Administration on Aging was combined into that Administration for Community Living. We're going to talk a little bit about OAA, which is Older American Act programs. So what happened with those? Well, back in 1965, President Lyndon B. Johnson signed 2 programs into law for the older adults. That was Medicare on July 30th and the Older Americans Act on July 14th. So it was really a good year for those individuals. So what is Older American Act programs? Well, we talked about the Administration for Community Living, which has the Administration on Aging. Well, the Administration on Aging oversees the Older American Act programs. The Older American Act programs provide services for adults 60 years of age and older. The Administration for Community Living provides what we call a notice of award to the State Unit on Aging, which is where I'm from. And that notice of award is like a contract with us. It tells us how much money we're going to get from the federal government to provide services to those 60-year and older adults in our state, statewide. So that notice of award, we can't do anything until we get that notice of award. We can't provide funds or provide services if we don't have a contract with them, which is our notice of award saying you're going to get this amount of money. All right, so we talked about Administration for Community Living, and now we're talking about State Unit on Aging. So those funds are coming down to the State Unit on Aging. The State Unit on Aging is in the Office of Community Access and Independence in Colorado Department of Human Services. Just like Administration for Community Living is in Health and Human Services in the federal department, we are located in the State Department. We administer both the federal Older Americans Act program, and we also administer the funds for the State Funds for Senior Services. And I'm going to talk about the State Funds for Senior Services in a little bit. Let's talk a little bit more about what our role is. So what does the State Unit on Aging mission or proposal to do? Does that mean? Okay. So our goal is to provide services to older adults in need, to help older adults stay in their own homes or in the community of their choice, to improve or maintain quality of life, to maintain their independence, and the State Unit on Aging agrees with that ACL person-centered approach, meaning that we look at the person around, and they're the ones that make that decision as to what services they would want. What else do we do at the State Unit on Aging? Well, we contract with the area agency. What we do at the State Unit on Aging is we contract with the area agencies on aging. So we get the notice of award, we get those funds, then we contract with the area agencies on aging, and we funnel that money down. What we also do is we review and approve any reimbursement requests that the area agencies on aging make. So what we're looking for when they send those in is, does the documentation back up what they're requesting? Are the unit prices in line? Or are we paying, $100 for a meal at a congregate meal site? That doesn't look right. There may have been some kind of data entry problem. So once we have reviewed those, asked any questions that we may have, then we approve those for payment for the area agencies on aging. We also conduct annual evaluations of the AAAs, which means we do a desk evaluation or an on-site evaluation. There's a lot of factors that go into that determination, but we follow that funding, so we also talk with providers. We talk with the area agencies on aging, and we look at the providers as well. We also provide technical assistance and policy interpretation for the area agencies on aging. Basically, what we want to do is we want to ensure good stewardship of those taxpayer dollars. And that's what we ask of the area agencies on aging as well. So, I said we were going to talk a little bit about the state funding for senior services. As you can see, there's two funding streams now. We have the federal funds and we have state funds for senior services that are coming into the state unit on aging. The state funds for senior services is a state cash and a general funds that we get. So there's two different pots of money, state funds. The state funds provide community-based services to eligible persons. We don't do any institutional funding. It's all community-based. So we follow the same eligibility requirements as the Older Americans Act. So in order to get those state funds for senior services, it's the same rules, the same policies, everything that's reflected in the Older Americans Act is reflected in order to expend those state funds for senior services. And the state funds for senior services must be expended during the state fiscal year that they were awarded, which is July 1st to June 30th. As I'm sure that you're aware, Colorado is a state that does not run in the deficit. Therefore, we must always have a balanced budget. And we must have a balanced budget when we begin July 1st. So we can only contract 1 year at a time. But we have the option to renew those contracts for 4 years. So we'll do a contract, and then we'll renew the contract for 4 years with an option letter. But those state funds must be expended in that year, or they're reverted back to the legislator, to the JBC. We have no control over that. Okay, so our funding flow here is federal dollars, state dollars going to the SUA. Now we add in the area agencies on aging, of which there are 16 different ones. And if you look at this slide, I want to first say that I don't believe in killing more trees than I need to. There's an error on this slide. So if you would start by crossing off 21,528,663, the actual number is the total of the cash fund of 11,527,234 and the general fund of 10,582,752. So the actual total should be 22,109,986. That's what I get for not reviewing somebody.
One more time.
Okay, one more time. 22,109,986. That's a lot of money. Those are the state funding for senior services that we received for state fiscal year 2017-18. So those funds need to be expended by June 30th. No problem. And then we have the federal dollars. Those dollars that are coming from the Administration for Community Living, that's the next part of this. That's $16,792,163 for federal fiscal year 2016-17. They run off of a different year than what we do. Federal fiscal years go from October 1st to September 30th. So what happens is we have a little bit of difference in time. So we're allowed to carry over, the area agencies on aging are allowed to carry over a little bit of that federal dollars for the next year if need be. But we run off of when we get our notice of award. Well, unfortunately, this year, our notice of award has come in small increments. So we don't have the full total yet for federal fiscal year 18. This is the amount that we have from federal fiscal year 17, which is $16,792,163. And it's broken down by parts because it needs to be expended that way. So if you take a look, Part B is your transportation, your in-home services, chore services, homemaker, that type of service. Your Part C1 is your congregate meals. Your Part C2 is your home-delivered meals. Part D is your evidence-based programs. And Part E is your caregiver program. And then Title VII is the dollars used for elder abuse and ombudsman. So those are how they're broken down. And that's how we receive those dollars from the federal government. Now, when you look at the funding history, you see that, let's look first at the green. Those are the federal dollars. They've remained stagnant. There has been no increase, basically, in those federal dollars. But if you look at the state dollars, since state fiscal year 14, we have had an increase. And the blue shows the total overall funding, which, if you look at that, our total funding for state fiscal year 18, $38,320,826. So it has continued to rise thanks to the state funds. So we're very grateful to the legislators for giving those extra dollars to us. All right, so now we know where this money is, and we know that the State Unit on Aging is the one that has these funds. Now, we're going to transfer those funds down to the Area Agency on Aging. There's 16 different area agencies on aging, and what they need to do is to provide a range of options to allow adults 60 years of age and older to remain in their community of choice. They help older adults age in place, and they do a mighty fine job. The one thing about the area agencies on aging is they may not provide the services themselves. They may subcontract those and have a provider provide the services. And I think here, I know that you contract like with Silver Key for congregate meals and things. Some of the other AAAs may provide that service themselves because they don't have anybody in their region that would be able to do the congregate meals or the home-delivered meals. So they do those themselves, and they don't contract out. Another way of doing the services is under a consumer-directed voucher program. Now, that voucher program allows the consumer to direct their own services, and they may end up choosing a friend, a family member, to provide those services. Now, the AAA, if they are subcontracting, they must monitor those subcontractors just as we monitor the AAA. So they need to go out and do an annual review just like we do. And as the advisory council here, you need to review the service needs within your community to be sure that those are being accounted for, that you are actually giving consumers what they need, and then review requests for proposals. If you send out requests for proposals for services and they come back, then you review those. That's kind of how the services are done within the Area Agency on Aging. So, if that's the case, now we have somebody else that we're flowing those funds down to, and that's the subcontractors. And those subcontractors must meet the policies and procedures and the regulations that the Older Americans Act sets forth, and what our State Unit on Aging Policy and Procedures sets forth in our Volume 10. And one of those is the consumer eligibility piece. And we say, the Older Americans Act says, this is a program that there is no means testing. And that means that you cannot determine eligibility based upon someone's income. So you can't ask someone, what is your income? Well, if you're making $60,000 a year, then you don't qualify for our services. You can't do that. It's not like Medicaid programs. You have to apply, they look at your income, they look at your assets. That's not what we do in the Older Americans Act. What the main thing with the Older Americans Act is you must be 60 years of age and older. Now, yes, there are some exceptions to that rule, such as grandparents raising grandchildren. It's only 55 years of age and older for that program. Or if somebody goes to a meal site with their spouse, let's say that one of the spouses is 62 years old, but the other spouse is 59 years old. The 59-year-old would qualify for a meal at the meal site because they are a spouse. They are declared spouse. We do try to emphasize or target individuals that are frail, low income, rural, and minority. But there are also some other services that have additional requirements or eligibility requirements, and that would be like personal care. In order to receive personal care, the person must not be able to do 2 ADLs. Now, ADLs are things that you would have to basically assist bodily with that person, like they're unable to bathe, they're unable to dress, they're unable mobility is a challenge. Or the other thing is cognitive impairment. That would then make that person eligible, as long as they were 60 and over, for the homemaker programs or the personal care programs. And that's also true of our caregiver programs. There is the 2 ADLs and or cognitive impairment. And the other thing, though, on the caregiver program, that individual must have a caregiver. So the individual must be 60 years of age and older. But the caregiver can be 25. But the care recipient needs to be 60 or over with the 2 ADL deficits and or the cognitive impairment and have that. Oh.
We've had a question come up recently about the caregiver eligibility. And in the rules and regulations, it doesn't, what we've been operating on and our providers have been operating on for the family caregiver is that either the caregiver or the care recipient can be 60. So a 60-year-old caregiver of an adult child with a developmental disability, we've been considering them eligible if the care recipient was under 60, as long as the caregiver was over 60. And then we read the policy and procedure, and it's not clear that that's okay. So we wanted some clarification on that.
If the caregiver is 60 years old and they're caring for a child with a disability, an adult child that has a disability, the Older American Act recognizes that and says that you can do that. Where the issue becomes is if the funding is available. When you end up with a wait list or something, you look at the frail, low-income, rural, and minority. But that is part of the Older Americans Act. It is. So, and I thought there was something in the policies and procedures about that. Let me look. Let me look at Volume 10. Maybe it's in Volume 10. But let me look at that. And I will get back to you, Lisa.
And there's also potential for payer of last resort issues in that.
That's exactly right. With any of the services, payer of last resort, Older American Act funds, which state funds for senior services, has to follow exactly what Older Americans Act is that they are the payer of last resort. So you have to look at that as well, if there's another payer. Okay. So what services are available? I'm sure that you're more than familiar with the services that are available here within Colorado Springs, El Paso, Teller, and Park. But the things that need to be in the Area Agency on Aging include information and assistance. That's a requirement. Home and delivered meals, which is also known as Meals on Wheels. Congregate nutrition programs. Nutrition education needs to be provided, and nutrition counseling. Those are requirements. Transportation, family caregiver services. I just have to say, I think I said, maybe I didn't say that at the beginning, that I also oversee the caregiver program at the state. And you guys are very fortunate because you have a great caregiver program here. You know, I think Kent Matthews does a wonderful job, and he provides some very good services. As a matter of fact, if you go down, some of the evidence-based programs that are available here in Colorado, Kent does both powerful tools for caregivers and stress busting for caregivers. So he's right up there. So you guys are very fortunate. Other things that are required is the legal services. There must be a portion of funds that go to legal services. There must be a portion of funds going to ombudsman as well. That's the Title VII dollars. Then it's personal care and homemaker is a choice, basically. And then the evidence-based programs, which is the chronic disease self-management, and then the fall prevention. So those are other evidence-based programs that are available in Colorado. And I'm not 100% sure. Do you do those, Joe? Oh. Okay, cool. Great. Well, then you'll know more about those. So actually, that's all that I have. Does anybody have any questions?
I have a quick question. So back on that second to the last slide with about the eligibility. So I know that the means testing, we can't ask them that, but what about the wait list? So how does that work? Because I don't know that everyone on the council understands that. So I know that there's times that we do ask those kinds of questions, but when is it appropriate, when is it not?
On our assessment tool, we ask individuals, do you fall in this range, or this range? The difference of asking and then making that a requirement on our eligibility, that's a difference. That's not part of our eligibility. However, there is a tool, which I'm sure Region 4 has, that was approved by ACL, and it's basically a priority wait list tool, and it looks at various things. It looks at the frailty, it looks at income, it looks at minority status. So then they add up the points of all of that to prioritize. So if you do have a wait list, you could use that as a prioritization mechanism.
That's exactly what we do.
Yeah, and because I know that there's been times when we have heard from our providers, a few times we have something about the tool or something like that, and I just want to clarify so that everyone understands that even though the question may be asked, that doesn't determine eligibility. However, if that program does have a wait list, that's when you kind of can use those options to be able to get those who need it the most, the care before those who may not be as needy.
Yep. And I would recommend that prioritization list. Yes.
When you go for eligibility, your assets, does this have anything to do with what you pay or you don't pay? Or
Under the Older Americans Act, we can't look at that. So it does not. Now, under Medicaid, that might be something that they look at, but that is not anything that we look at as to, are you talking about if you pay rent at $500 and you pay medical costs of $200, so that leaves you only $100 extra dollars? We don't look at that.
if you have assets that you can sell or whatever to have to pay or
No.
get the service or?
Everything's income-based. Assets are not considered.
No.
Oh, okay.
Yeah. We do not look at if you own your own home, if you drive Mercedes-Benz or we don't look at those things. So, yeah.
Other questions or comments? I would just like to thank you very much for giving this presentation, and I've been on the board, or a member of the RAC for a couple of years now, and this would have been an ideal thing to have as a new member first walking in, to really get an understanding.
Yeah, I know.
Wow,
We're all
so
going,
that's
Joanne's
where it
really lucky.
comes.
This is good.
This is really huge, and I think that especially it will also be very useful, I think, for the TRS, Technical Review Subcommittee, just to have all the formulations here, and you can kind of see how the money flows and the rest of it. We hear the presentations, we get pieces and parts of it over time, but this really was very, very valuable. I really do appreciate your coming. Thank you.
Okay. Peggy, can I ask one more question? Is there a possibility, is this something that only you can share, or is this something that we could make copies of and have as part of like a new orientation for new council members as they
Right.
come in? As
Exactly.
the membership chairman asking that question.
You can use it
Okay,
however you
great.
want, as long as you correct the addition error. Then you
I
can
will
use
put
it.
on there, Peggy messed up,
Yeah.
so, yeah. No,
And
but
I'm
I
not
do
going to
think-
throw anybody under the bus, but
But I
It's a
do
me.
think that just as this is part of the packet, because I do think, I don't even want to say how long I've been a part of this organization, but figuring out from where the different locations come
Exactly.
from and how it funnels down. Again, you hear about it, we know that when there's a carryover or things like that and for the funding, but this was very concise and quick way of being able to kind of bring it together, so.
Very
We'll make
meeting
some
and very
copies.
complete. Go ahead.
Is it carryover then, because of the different in fiscal years? I've never understood how that works.
No pressure, Peggy.
Federal budget process, will you? Go.
She would have liked to escape without my, I have a bad
Well,
pattern of doing it.
no, the carryover that I speak of is that because we are on a state fiscal year, which goes July 1 to June 30, that there's still 3 months left in that federal fiscal year. So they go October to November. So they're allowed to carry over. Our AAAs are allowed to carry over funds because we contract just until June 30th. They need those extra 3 months. So we allow them that opportunity to carry, but we had set a limit on that of 10%, that you could only carry over 10% into the next fiscal year. Last year, because we were having, believe it or not, some financial things going on at that time too, we said, okay, whatever you have, we'll let you carry over. But the problem becomes state dollars need to be expended June 30th. So it's very difficult to do a AAA budget because you're not really sure, are we going to have a boom in congregate meals, or are we going to have a boom in, another area of services that we're going to need to put the money over there, or is congregate meals going to tank and we're not going to do, we drop congregate meals by, I don't know, a tenth or something. It's hard to balance that out. And when you have to have those funds spent by June 30th, it's better to expend those state dollars and then carry over those federal dollars those 3 months.
Well, I appreciate you explaining that, because I've been on the technical review committee, and that's what I assumed, but I never
Yeah.
verbal.
Yeah, and the federal budget is very. When Carrie asked me to do this, she said do an overview, because the federal budget is extremely complicated. Because you get funds and from 3 years ago that you could do this, and it's just kind of different. But what I'm talking about, that 10% is our rules and our guides to carry over, just to make sure we get the state funds expended.
I think Lisa has a question.
Oh.
I have a comment.
Okay.
In our region, we have other family caregiver providers that are doing a really awesome job. The UCCS Gerontology Department provides family caregiver counseling and information services. Teller Senior Coalition provides counseling and respite, and Park County provides respite as well. So as far as family caregiver goes, we've managed to patch together between us and our providers a really robust family caregiver
And-
program for our region.
That's really great to hear, because I think, I do a respite grant as well, and respite state funds, and oversee the caregiver program. But I thank anyone that does any kind of caregiver anyone that does it, because I truly believe that caregivers is where we really need to focus right now. Because someone was telling me that at a recent meeting, someone made the comment, we have over 800,000 caregivers in the United States. What happens if those caregivers decide they don't want to do it? We're in a world of hurt. So we need to take care of our caregivers. We need to assist in any way that we possibly can. So I greatly appreciate that. I also think, though, that we need, congregate meals because we need the socialization. I think we need home-delivered meals. So I think that we need just about every service that's around. And Alzheimer's Association is who I have the dementia grant with. I think they're great. So I think everybody is doing really good work, and it's not work that is, that people take lightly, I don't think, because these individuals need help, they need services, they've done so much for us that it's time for us to do for them, I'm just glad to be in the aging field. That's my...
Another question over here. In the...
Oh, yes.
I had a question about on the auditing side.
Later.
The oversight. There's been a trend more and more towards heavier, stronger, deeper audits. Is that a continuing trend that we should expect to see for the next few years? Or is that there's been differences in some of the regulation? There's been advising that there's going to be less regulation coming from the federal government level. There's been information that says that grants through government grants will be paying the full cost of providing service, but those haven't necessarily been what we've seen play out. Do you have a sense of what to expect going forward?
I don't. I don't do the monitoring and the evaluations, and some of you may have met Candace, who was here doing an on-site. She has moved to a new position, a promotion, and so I don't know what's in store. Her supervisor is now Greg Smith, so I don't know what those are going to be. I don't know. So I used to do monitoring, but I'm not in that anymore. So I'm sorry. I don't have the answer for that. But if there's something that you would like to discuss, I would talk with Lisa, and Lisa, you can contact Greg. So.
Anything else?
One thing I do know is with a new evaluator coming on to take Candace's position, we're going to see a learning curve. We're going to see a difference in focus. So it's going to feel like things are changing when really it's just a person in a position and they're at the level of their focus, and whether they're like digging down and detail oriented all the way to the bottom of the pyramid, or if
Stay at a higher level.
more service
Yeah.
focused. So there's going to be change, and there's going to be a learning curve. So I think we can expect that.
Well, and the one thing that, we need to keep in mind is that when we come out and do monitoring, really what we want to do is provide technical assistance. We want to ensure that policy and procedure and regulations are being followed, and that we're good stewards of the taxpayer dollars. But the other piece of that is, if you remember that bar graph, the state dollars were going like this. When you start getting those kind of funds, state auditors start thinking, they're getting a lot of money. We better make sure that they're good stewards of taxpayer dollars. So that's the other piece, that we want to be sure that if we go under another audit, that we're doing a good job, that we are able to say, oh no, we're following these, we're following this. So that's another part of why there's that monitoring going on. But as far as how anything's going to change, I don't know that. But you're always wondering when, I don't know how many of you were here in 2005 when they did the state audit then. So, but Yeah. So anyway, it's about coming to be our time.
If I could add one quick comment while that visual's still in your mind of that flow chart of money, oftentimes I get asked, all of us are becoming way too familiar with the term continuing resolution, and people wonder why does it take so long once Congress has passed something for that money to get to us. But you have to visualize it goes from that authorization to HHS, to ACL, to the State Unit on Aging, to the AAA, to you. So there's several steps in that process, and each one of them takes probably a week, week and a half. So generally you're looking at 5 to 6 weeks once money is authorized to get to us. And that's assuming that there's enough money to even give somebody something.
Yeah, and sometimes at the state, you can, it can take longer than a week or 2 weeks to get a contract through, so.
Well, thank you again. I really do.
Thank you.
Very well.
Thank you, and thank you all for your work.
Okay, the next on the agenda are information items and a presentation by a provider, UCCS Aging Center. And it's Dr. Sarah. It's pretty amazing.
Good evening. It's so good to see you all. I'm Sarah Qualls. I am the director of the UCCS Aging Center. I've been at UCCS for a long time and in this role for a while. I'm going to try to do a quick overview of what we do and how your funds, the funds that you administer, are flowed through us to the constituents in this region.
Arrow key?
All right.
There you go.
The Aging Center serves older adults and their families, and the Aging Center as a whole serves 55 plus. Obviously, the programs that are funded by the Older Americans Act dollars serve 60 plus. But we have these 4 basic programs, and I'm going to spend a little bit of time talking with you about those really quickly. If you look at the top, we are essentially a mental health facility, including mental health training. So we're the training clinic for a doctoral program in geropsychology. We train people to be specialists to work with older adults. We're one of a handful of programs in the country that do that, which seems kind of silly given the demographics, but it's true nonetheless. So if you look at the top, we provide individual psychotherapy, and then we provide caregiver interventions, and at the bottom is our memory clinic, and on the left are neuropsychological evaluations. And I want to just comment quickly that when caregivers seek intervention, once in a while they walk in the door and say, I need tools, or they walk in the door and say, I'm stressed. That does happen. Many, many times they walk in the door and they can't quite articulate what they need. They don't even quite know what ballpark they're in. They just know something's not right. They may be trying to figure out how not right. Is this normal? Is this not normal? I'm frustrated. Is that a problem with me or with him or her? It's pretty ambiguous. And so part of what we do in our contracted services is really focus on helping the caregiver hone in on what they know about the care recipient and how accurate their understanding is. And because 70% of the caregivers we see are dealing with cognitive impairment, those memory clinic and neuropsych evals end up being really important in the services we provide as a package, even though they're not funded by you. So let me talk first about caregiver counseling and what we do. Last year, in last year's fiscal year, we had 87 unique clients. We did, as you can see, over 1,500 service units. We provide, the way we package our program is that a caregiver coming in can access up to 8 sessions in one fiscal year. They may do 2 and hold off and do 2 more and hold off and do 2 more, or they may do 8 weekly. It really depends on the need. We also can provide for them participation in a group. We have a caregiver group that's based on the model, the coping with caregiving model that Dolores Gallagher Thompson and her colleagues at Stanford created. That's an evidence-based approach. And then we do caregiver workshops as a way to give people a toe in the water when they're not sure what they're dealing with and they wouldn't sign up for multiple sessions. It's been a great strategy for us. We're on track this year to have that number and plus some. So over the course of the work that we've done, because we're not a dementia caregiver unit solely, we have caregivers that walk in the door and they're dealing with ALS or they're dealing with diabetes, they're dealing with all kinds of difficulties, blindness in the care recipient. So we had to create a model that was evidence-based, and I could train trainees to do it quickly. I could train them quickly to do it, and it would address the broad range of caregivers. So we have developed this model. We have a book out, we have a video out. It's now in testing, and we're collecting data on our model. How do we do this work in 6 to 8 sessions? How far do we get? What are the exact outcomes? Those are the pieces that we're examining at this point. And we basically walk through a set of questions in our own mind. Is it clear to the caregiver what they're dealing with, or do we need to help them name the problem more accurately? Is care structured appropriately? In many, many cases, the problem with getting care structured is that the caregiver, herself or himself, can't quite figure out how to get the care recipient to receive the services. That's a very common problem. Dealt with it this week again in 2 or 3 cases that we're dealing with. Yes, ma'am.
What kind of training does the caregiver get?
So it depends on what the caregiver needs. If the caregiver needs training in figuring out how do I negotiate someone who doesn't want someone in our home, then they get training in how do you communicate with the care recipient to keep the services moving forward, even though the care recipient's worried about it or scared about it. It's so individualized. I mean, that's the nature of counseling, is that it's tailored. And we know that from all of the caregiver data in the U.S., is that the one thing that we know has to happen is we have to tailor a service to the individual.
So you train the caregiver for each individual case that you get?
We do. So if you're dealing with a care recipient who's blind and cognitively intact, but is really, really frustrated, which I'm picturing a case right now where we've dealt with that, we'd be training that caregiver in a different set of skills than if we're training someone who's dealing with late-stage dementia and they literally don't know what to do with the behaviors that they're seeing. I mean, they're just apples and oranges. So we have to be flexible. So we've created a model that helps us be really clear, what does this care recipient need, and therefore what does this caregiver need, and what do we have to do to empower the caregiver to be able to do what's needed. Does that make sense?
Yes, it does.
Okay. It's one of the challenges that we face when we do packaged programs like a tool program. I mean, it's fabulous if somebody comes in knowing they need the tools, and they're set up where they're flexible so that lots of caregivers can benefit. However, we get the caregiver who would never walk in the door for that class, and Jody gets this too. You have to start wherever they are with whatever language they use for the problem in front of them, which may be really not a useful description. He's just obnoxious. That would be a language that we get. And occasionally I would meet the person and agree the behavior is obnoxious. And now what are you as a caregiver who's been the wife for 60 years going to do about that behavior? And how are you going to survive and how are you going to walk through the process?
When you say tools, are you talking about the training that you give the individual? I mean, tool is...
It's a generic term. I'm using it in a generic way. So it's very common. Let's use me. When my mother had a massive stroke and then developed a dementia, I had to figure out how to be a daughter who was respectful and who said, "No, Mom, you are going to walk today." I had to figure out how to do both of those. And we see a lot of caregivers that get really stuck. If Mom doesn't want to walk, how can I make her walk? But if she doesn't walk, she's going to decline, and then we're going to have more problem. It's a role change. I had to figure out how to be a daughter differently. Many, many people have to figure out how to be a spouse differently, a sister differently. And they may know what to do, but they can't figure out how to do it and still retain the humanity in their relationship that has a 10, 30, In my case, it was a 50-year history, right? And so that's a lot of that individual coaching, individual counseling that's required to help you be able to do what you need to do, which is different from you and what you need to do. You see in this model, for example, self-care sits there at the bottom left of the curve, because what we've learned is that if a caregiver walks in the door and we start talking with the caregiver about handling her stress, but she doesn't feel like the care recipient's needs are handled, we won't get anywhere in that conversation. So we have to first make sure that the care system is structured. Then, okay, now let's talk about how we're going to sustain it. How are you going to stay healthy to do that care system that you're good at doing?
So you get into this, training them for whatever the recipient is acting like.
Exactly. Let's deal with what's here now. And the last step that we do before we finish is we say, what's likely to come ahead? This is almost all of what we deal with are chronic diseases that are going to decline over time. And so this is this moment. We got it stable. How would you know it's not stable anymore?
Well, the thing about it is I do understand what you're saying. I know somebody that's 94. Anyway, she herself, she says, well, I just don't understand how come they're coming out every day. I says, I'll tell you why. Because you'll sit in that chair if they don't come out and push you to get up and walk to where you can be self-sufficient. Oh, well, I said, no, it's not an oh, well, it's the truth. And her daughter tries to get her to do it, and it doesn't work. I'm going to do what I'm going to do. Okay. You know, so you really, it is quite a hassle.
It's really hard. And what you could say as a friend and what the daughter could say might be really different. And so how does the daughter do what the daughter needs to do and not have her stomach in knots because she's being a bad daughter?
Right.
And so how do you navigate that? Families, I mean, what Peggy said is so true. The estimate that the National Alliance on Caregiving gives is that if we took away all the care that families do for older adults in this society, it would equal the value of the entire federal Medicaid budget. Oh, it's massive. And so our health system is totally reliant on families. That's a whole different lecture I could go into, but how we don't loop families into that system. We keep them separate. But the healthcare system is, and you're going to see in a few minutes that one of the things that you all help us do is to partner with the social service system the same way, and Silver Key. And we've got these silos, and they don't work very well because families don't live in silos. Families are in the middle of it. And we've got to figure out ways to get our family services wrapped around all those different silos. So that's our model. I've got a story. Here's a classic one, and I might be quoting you. Every time I try to talk to my mother about live-in help, she would cut me off. I would hire meal or cleaning services. She would terminate them the first time they came. I was reduced to dropping by my mother's home 5 or 6 times a day just to make sure she hadn't fallen or that she'd remembered to turn off the stove burner or she hadn't locked herself in the bathroom. My mother may have been independent, but I was a prisoner. And I would bet that Jody would tell you the same thing from the Alzheimer's Association, and that is that by the time we see families, their fingers are in so many dikes, they have so many fingers stuck in that they can't move. And so the caregiver service, I would love to get it sooner. I would love to get all of us in our 40s thinking about this. I don't think that's realistic. And I say when my kids were in preschool, I really would not have paid any attention to anyone telling me what my job would be as a band mom in high school. I wouldn't have tracked it. I wouldn't have thought about it. So in families, we need information on a need-to-know basis, and it needs to be wherever we are. And I do think Peggy's right. This community has a remarkable richness of caregiver services compared to almost anywhere else in this state, where you can walk in the door and you can get Kent. You can walk in the door and you can get us. You can walk into the Alzheimer's Association. We have so many no wrong doors that you can get into and get to the services. And what I hope you will know is that we're there and we're part of that service network, and we appreciate the opportunity to do that. In order to get to all these caregivers, we do the public information that other people do as well. So we see lots and lots of people. We partner with everyone we can think of to try to get the message out that we're here for caregivers. And so we've got lots and lots of partners. In our training program, one of the things I'm committed to is training psychologists to communicate to the public. So our trainees are required to write for Life After 50. They're required to do public presentations during the year. They got to learn how to translate all that technical psychology language that's in their head into language that's useful to people. And so it helps us get even more things out, and that's great.
Sort of piggybacking on the partnerships there, one of the big strengths of the community really is the religious community and the nonprofits that are focused on various missions and activities. But at the same time, the churches themselves are doing an awful lot of interaction with the caregivers. So is there an interfaith council or some mechanism that would be in the partnership area that you could say, okay, so these are the services and this is the concerns and the needs? Is that another avenue perhaps to get information out to the community?
I think it is. The one that I've been most connected with is the, what are they? They used to call them parish nurses. They don't anymore. Somebody help me. It's faith.
Well, Penrose, faith-based.
Faith
community.
okay. There's 2 or 3 different organizations, but next month I will be doing an all-morning training for the Penrose-based
Okay.
John Zonlow's group, and they're opening that up on our model. How could they use that model?
Right.
And I also go in and do this presentations for Stevens ministry groups, for
Okay.
example.
Exactly.
And I think those are great outreach
Right.
connection points that we've used well. The main minister, the Interfaith Council, the main ministers group, senior ministers,
Yeah.
not so much.
Not so much, okay.
Yeah.
All right, thank you.
We just haven't had the entree there. So we've learned this workshop format. This is the one we did in November. We did this cool partnership with Ormayo Dance, where we did a half day for the caregivers, and we got, at the end of it, they got to see a little preview of the Ormayo holiday event. It was sort of a treat to them. It was a nurturance for them. We do these half-day workshops about once a quarter, and Mackenzie Place has been gracious to host them and provide a meal for them, and so it's been a really lovely model. We have about 45 people each time. So I put a couple of stories up here. Recently, we had Ted actually did a little TV piece, you may have seen or not, around the holiday time. But Ted's a local community member whose mother was 86, and he was just at that finger in the dike point, and he walked in our door. He did our individual intervention, and he did caregiver group at the same time because he was just so fried, and his wife was cheering him on at doing that because she recognized how fried he was. And classic intervention. And a really different approach is Nancy at the bottom is somebody who had a mother who'd been troubled her whole life. Chronic depression throughout the life, difficult mother-daughter relationship, and now the daughter's in charge. And what do you do, and how do you cope with the need to be very involved with somebody who's been very hard on you, and it's been very painful. So those are scenarios that we walk through. So I want to switch gears then and talk a little bit about our senior outreach service program. Before I do that, let me go back to caregiving. Any other questions about caregiving before I move on? The last thing I want to comment on, if you remember that initial circle, keep in mind that we do psychotherapy and we do evaluations of cognition. And because that's all in one place, that's been so helpful to us. Because some of our caregivers aren't done in 8 sessions. They are difficult humans. They've always had difficulty with life, and now caregiving has presented them with a serious difficulty. And 8 sessions, they don't need help just with caregiving. They need help with life. And so we then transition them into our therapy program. And other ones just need information. Often, it's not easy to get a clear answer about your care recipient's condition. Is that an understatement of the universe? But it's the case that you take someone to multiple appointments and you've got 3 specialists and you're still trying to sort out, now what really is going on and what can I expect? And so we try to help put that package together and understand that.
Are the students involved in that process as part of their training?
They are. We have 2 service lines in our clinic at this point. There's a Medicare service line that's people can access services by licensed psychologists, and that's all funded through Medicare. Medicare won't reimburse for anything students do. Anything that the students touch is, in psychotherapy or assessment, is done under a sliding scale. And we try not to turn anyone away. And I will say, I think every single week I sign a request for fee reduction from the bottom of the scale, which is $5, down to $1. And we will do psychotherapy for $1 if that's what it takes, because they need transportation to get there and they don't have that money. So it's a commitment, exactly. Yeah, that's right. So, moving from caregiver now, I think perhaps one of the more exciting programs that this community has is our Senior Outreach Services program that we do at Silver Key. This program came to this community because in some other communities they've used a program called Senior Reach, which came out of the mental health center, and it was an outreach program for the mental health center. And in our community, we had a very large working group that worked for a long time to think about this together, and we realized that in our community probably our best entry point was Silver Key rather than Aspen Point. And so we've been partnering on this for 3 years, and we have built out this SOS program. So the mission of this program is to identify and provide services to at-risk persons who are 60 and over. We do that by training people in the local community to refer older adults they're worried about. And our goal ultimately is to make a positive impact on seniors to maintain independence. And this is focused on mental health. So what we know is that many people are isolated. They suffer in silence. They are burdened by financial strain, relationship strain, grief and loss. You name the problem, and when the burden lasts long enough, it turns into a mental health problem. You've probably been sensitized now to the relationship, for example, between loneliness and healthcare. We now have documentation from multiple longitudinal research studies that document that loneliness predicts morbidity and mortality, illnesses and death, better than blood pressure does. It's powerful. And so SOS is designed to help us get out to people who are isolated and might not otherwise be recognized but have mental health issues. And here's how we do it. Well, you can see here the case management we do together, and I'll explain how we do this, and then we move them into counseling through funds that you administer. Here's how it works. You identify somebody that might need help. Maybe there's newspapers piling up in your neighbor's driveway. Maybe there's somebody that you know has fallen, and you know they haven't gotten services, and now you have signs that the behavior has changed. They're not going out when they normally go out. You call the SOS line. Silver Key case manager contacts the older adult and says, someone's worried about you. Could I come out and visit? And the Silver Key case manager goes into the home and does an assessment in the home just of how they're doing generally. Usually, in the course of that, they identify some services that that person's eligible for that could support them, that are Older Americans Act type services or something else Silver Key does. Then there is a conversation around a table in which the case managers and our mental health person and myself and our project manager, we sit around a table and we staff every case that they talk to. And sometimes my ears perk up and I say, I just wonder if we're dealing with substance abuse here. I just wonder if we're dealing with cognitive impairment nobody's noticed, because it just sort of sets off my antennae from that mental health angle. And so then the case manager asks permission for a behavioral health person to come into the home, a clinician to come into the home, and begin psychotherapy in the home. And we begin an assessment in the home. And people are often very open to that idea. They go in the home, and we begin. Sometimes we have a number of hoarding cases we're working on right now. Sometimes it's anxiety disorder. Some of the scariest ones are when somebody clearly has very serious cognitive impairment. I'm remembering last year, the person I say, I know there's one person in the universe that we saved last year, and I know it, because we encountered a woman through this program whose daughter lived in Denver and was involved and wanted to be caring, but was moving too slow because of issues in her own life. And this woman needed to get into assisted living. She was 83 pounds, was cognitively impaired enough that she had forgotten how to use a can opener. So she had food sitting there, but couldn't remember how to use a can opener. And the mice had eaten all the food that wasn't in a can, and they were everywhere. And so we had to work with Rocky Mountain Options, of course, to get her into long-term care. I mean, it was a long process. We kept visiting during that process to make sure that we didn't lose that person. We see a number of those, some not quite that dramatic, some that dramatic.
Actually, Sarah, just a little bit of a applause for all of you. I actually went through that whole process just last week.
You did, by
So,
calling?
I made a call. We've had someone that is a church, an association that we have, and a group of other people within the organization, the church, has actually been trying to help. It's the bishop, the president of the women's services, 6 different people all trying to help this one individual. In the past, APS has been called. Nothing's really has done much. But it was interesting, so I said, you know what, we're going to do the SOS thing. We called Candy Lachat, did a great job having a conversation with her. Unfortunately, it didn't go very far, but it did what it needed to do. Because in the email reply back to me about her conversation, the recipient actually quoted, "Oh, everything is just fine. If I have a need, my church friends will take care of me." And so in our conversation as a Care Team Faith network of 6 people, I recounted that to them, and they were all like, "What?" It was finally their realization that they were doing too much, that they were, not that they don't, because they love her and they want to care for her, but they were doing so much that she had no insight into how severe her situation was. And it was very eye-opening for them. And so even though it didn't go process the whole situation, it was good for them to realize that they were not helping in a way that was actually getting her to an end result that she could actually take some accountability herself.
We staffed that yesterday, and there will be a next step. So,
well, she's already in a facility because she got, it's so,
Yeah.
things happened actually, I think, the way they needed to, because now she's in a rehab, realizing that if she can't get off the toilet, then she probably shouldn't be going home by herself.
and a piece
So
of it is
help-
that she may never have that insight, but that if your group knows what it can't do, then we have to use other levers. And we get referrals all the time through SOS from APS, because it isn't bad enough for them to act and take away rights, but it's bad. And so we step in and we work back and forth all the time between the Silver Key case managers and SOS and APS and us around these difficult cases. Because one of the nastiest aspects of cognitive impairment, almost any of the dementias, is that people often don't have an accurate understanding of their ability and inability. And so they believe they have a little problem and you're making way too much of it, and they really can't see the problem. So we get in there, and that, we may use the physician for leverage, we may use an attorney for leverage, we may use APS, but we can go in the home even and do assessment in the home. And so it just opens an outreach avenue that is pretty critical, I think. Thank you,
exactly
Wendy.
what we needed.
Yeah. So this is kind of what happened. So you get Wendy's call in number 1. The case management contacts the client. If it's just case management services and there's no mental health, then they just handle it down at the bottom in 2A. If there's a need for a home visit or an office visit, then they complete the basic SOS assessment from the case management side, and they may enroll in Silver Key services going up that are supportive, nutrition, transportation, et cetera. That we discuss it in that number 4, that core meeting, and then it may get referred to us for mental health assessment, precognitive assessment, treatment, et cetera. Or our newest thing is that we've brought Aspen Point now into this partnership, and Aspen Point has a care manager that can also get involved, because some of the people we see are going to be long-term, and they're going to need med management, and they really need to get in the Aspen Point system, but they're going to make appointments and not show up, and they're going to get kicked back out of that system. And so we've got a care manager that's trying to navigate that. So we're giving that a try. It's an exciting adventure. If we succeed at this, I'm going to retire. How's that?
No.
If we succeed, no, it's the mea culpa to get this. Well, Pat and I are going to go off in the sunset and live in Tahiti. I mean, this is the kind of collaboration that there are 90,000 ways for it to fall apart. Let me just say. There are 100,000 ways for it to be powerful and important, but it's so hard to keep together, and we're working it. We're just working it. We're kind of pit bullish about it. Got our teeth in it, we're going to do it. So what you can do to help is what Wendy just described. You can call. You see a house in disrepair that wouldn't have been otherwise. So you know someone's getting more frail. This is the kind of scenario where sometimes the case manager walks in and smells the sewer backup in the basement that nothing's been done about, or sees the bruises from the falls and the person hasn't been out of the house so nobody knew that, but they're falling chronically because of balance issues, substance abuse, whatever. So we're just obviously incredibly grateful for the support that comes through the Older Americans Act to us, and we're trying very hard to be good stewards of it, doing outreach and creative innovation as best we can, grounding ourselves on the evidence base, doing the research we need to add to the evidence base, and training that next generation of people that are going to help us all. So that's who we are. Mm-hmm.
Is there a comparable organization in the Denver area or Pueblo or anywhere else?
Not that I've found. Not that I found. I mean, the Area Agency on Aging in Denver, under Dr. Cog, will have its subcontracts and its network, but I have not found an aging center. I have a couple of private psychologists that we train that are in the Denver area that I just channel people to because I know they know what they're doing, but I don't know about it. I don't know about it. I mean, there's one at USC, University of Southern California in LA. There's one in Tuscaloosa, Alabama, because that's where the geropsych programs are.
But even that SC one, nothing like that.
It isn't. That's true. What they have that we don't have is their state funds Alzheimer's services that our state doesn't fund out of the state. So they do the contracting for that, which is kind of cool. But
what are the extent of your service? That was you don't know what I'm talking about. What is the area of your services?
well, for the people who drive to us, we're constrained only by the funding, which is El Paso, Teller, and Park County. For the people that we outreach through SOS, it's a little bit pragmatic. We try to cover the whole region, but sometimes we struggle. Like, we have one referral in Cripple Creek, and we just can't do that. If they give us a half day, we'll go to Cripple Creek. We struggle with that. We just struggle with a service unit, which is a 3-hour turnaround. I can't do that. But we do, pragmatically, we do Monument to Fountain, out to Falcon, been to Peyton a couple of times.
You haven't been to Ellicott?
I don't remember I've been to Ellicott because I go out for the health fair, but
But if
yeah. But we've had people come in from Ellicott.
Yes, that's because I send them.
Thank you.
if transportation were provided, do you help people outside of your service area?
So if someone wanted to drive up from Pueblo for a service,
Yeah.
we put them on the sliding scale or the Medicare. We just can't bill the caregiver contract for that, right?
So the caregiver counseling that you're providing, I'm from Teller County, do you do most of that by phone, or do you want it all to be in person, or how does that work?
We need to do it in person usually. We really haven't moved yet into serious telehealth. We need to, but we really haven't.
Would you be some days when you're doing it like Skype or something like that?
Yeah.
At least see face to face.
It's not HIPAA compliant. So we've got some challenges to walk through in that process, so we have to be careful. And I think that's, that'll be something, a place we go. In my mind, we serve western Kansas and southern Colorado, in my mind, because there's no one else there. And so we do assessments on people who come from all over the place. We do neuropsychs, et cetera. But in terms of serving the caregivers through this funded program, we just have to put them on a sliding scale.
And I want to throw my 2 cents worth in. You folks are probably tired of me telling you how lucky you are to live where you are. But we live in a community that has 2 or 3 programs that are not only the best in the state, some of them are the best in the nation, and this happens to be one of those. So feel lucky.
We're blessed. Thank you very much.
Thank you.
Appreciate it. And next up, another provider presentation from Rebecca Janacek and the YMCA. Carrie's running over to get the slides up, right? No slides.
No, it wasn't already in there. A lot of reasons for that you wouldn't want to hear about. So I'm the only one without a PowerPoint. Mine is a lot simpler than the first two, Peggy's and Sarah's. I love coming, getting to talk about our programs, but I always learn so much. You know, it's like my mind can hardly, well, I should say can't, take in that whole overview about the funding and how everything's related and all the departments and agencies. It's amazing. It's just wonderful that we're a subcontractor. The YMCA also is a huge organization. I've been employed by them for going on 9 years now, and have been coordinating the Matter of Balance program for 8 years, shortly after the first time that they started receiving some funds from AAA and offering the first balance classes. So, in times past, I've tried to completely separate the programs, and then I'd keep giving an exception here and there. I'm just going to kind of lump them together. I'll do a real brief overview of each of the two evidence-based programs that we're able to offer through the YMCA, thanks to funding from AAA. They're both evidence-based fall prevention programs. They're both across the nation. One comes out of the East Coast and one out of the state of Oregon on the west. The Matter of Balance program is a 2-hour class once a week for 8 weeks. And it's what I call a holistic program in that it's 12, usually about 12 people sitting around tables. And it is the role of the coach is to be facilitators in a lot of discussion, a lot of material that's presented from the curriculum, but also a lot of material that's presented from the people around the table that are there to take the program. When I say holistic, it looks at things other than the physical aspects of what causes a person to fall, like lights and shoes and grab bars and all the, various physical things that come to our mind when we think about fall prevention measures. It also looks at our attitudes about aging, our thinking patterns, how we talk about falling, how we think about falling, and our habits. Obviously, habits are things that are going to govern our lives more and more as we age. So I'm always telling people almost on a daily basis in one class or another, we have to develop those healthy, safer habits now, because at some point the memory becomes less sharp, or there's illnesses or medications, and then we tend to function out of whatever our habits are. So we spend time looking at that. That program also has very specific balance exercises in 6 of the 8 classes. That's about 30 minutes of a 2-hour class. So that class is developed for people that are really afraid of falling, whether they've had a serious fall or not. Most of them have, but the fear is there, and fear within itself can be another risk factor for falling. And that's why the program was developed back in the 90s. A nurse out in the state of Maine realized that the seniors that she worked with, which was primarily her clientele, they were not getting assistance with fall prevention. They were getting services after the fact, medical services, hospitalizations. They got help for illnesses and medications and all kinds of things that they needed, but they were still falling. And that's where the impetus, and I always like to mention that. It's just amazing. So that program's been going strong. It's in most every state in the union. Then the Moving for Better Balance program, also evidence-based, came out of the state of Oregon with Dr. Lee, the researcher. And that is a program, and Francis was just asking me something right before the meeting started today about, is Tai Chi ever involved as part of a balanced program? And that definitely yes. The Moving for Better Balance program is a 1-hour class twice a week for 12 consecutive weeks. So that curriculum is a 24-class program, and it's mostly standing. It is based on 8 Tai Chi moves that are very well researched, and he keeps tweaking it. He's still researching it after all these years. So they started that as a pilot program in 5 cities, and Colorado Springs was chosen to be one through the YMCA. So we implemented that program. They trained a small group of us, and then we each taught like one class that first year, and you all were on board with the funding right away when that one came down the pike. So it was such a success. You've been funding, and we've been teaching that one ever since. And now we basically teach 12 programs of each type. So the Moving for Better Balance program, we can take up to 25 people. 20 is more optional, and the YUSA administrative offices really prefer that we have 15. As instructors, we feel that 20 is a very comfortable number because our goal, like in any group exercise movement class, you need to keep an eye on everyone. Make sure those chairs are available if someone needs to take a break or they're not feeling quite well that day, that sort of thing. So that one is not discussion-based, but there is some discussion that takes place, of course. So we teach those basic moves plus an open and closing move, so 10 moves total. And then they have lots of other things that we pick and choose from depending on the group that we have, called mini therapeutic movements. So there is a little bit of, not flexibility, but we have a little bit of leeway as instructors to really meet the needs of the group that we're working with. And that's true for both programs. We just we're determined to stay true to the researched material. So all of that gets presented, and then you kind of get to, you put on the specific outfit, so to speak, and then you get to accessorize it a little bit to meet your audience.
Your Alzheimer's and your dementia, do you have classes? They say you've got to keep your brain moving and all this. Do you teach that?
We don't.
Exercise?
Well, it is part of it. It's not a separate program within itself. That would probably come out of the Alzheimer's agency. But like the sequence, for example, of the Tai Chi moves, this is not a Tai Chi class. It's actually simpler to learn than a regular Tai Chi. I'm sure many of you have probably done some Tai Chi. It's generally a long sequence, and it's not what I would call symmetrical. You may do a move in one direction, turn another way, and so forth, and then come back and go in the other direction or go to the 4 corners. In this program, we learn the move, we do it to the left, and we do it back to the right. And the purpose of the program being put together that way is that it's easier for people with no background to learn it. And our goal isn't for it to be complicated. It's to learn the valuable movements that have been proven to help improve balance. And yet it's still a challenge mentally to remember the sequence and the flow and which arm goes where and how you step and so forth. So is that the kind of built-in memory?
Well, I think so. I know that I have this friend that does have dementia.
Okay.
Jody and I have discussed it. We've tried to get him to get second. And they said exercise, which he comes to the Y.
Okay.
And he does the exercises. And I guess it's in the aspect of keeping his brain going, as like you say, it can get what moves they have to make, they have to know, or they're fumbling on it. So it's a matter of balance. So I guess I was just curious because I do know that he does go there.
Okay.
For that reason.
And exercise is well proven to help kind of all aspects of our functioning mentally, of course, as well as physically. So there is some of that, and again, depending on the group, I mean, after the group, then those first, say, maybe 8, 9, and by week 10, everyone knows the sequence. And then we can do some really fun, clever things with how to mix it up. You know, call out a name, and we can do them, and we can change the sequence. We can do half of a move one way and then do the next move the other way, you know, all of which challenges the brain. One other thing that's really good, I think, keeping the brain sharp is using opposite sides of our body, that kind of that bilateral, you know, and the moves certainly incorporate a lot of that. You know, you're doing something with one foot and everything else is over on this side.
That's great if they
Mm-hmm.
Yeah, so Rebecca, I have.
Right, and we give them cheat sheets and a DVD, which is cheaper than the book.
Okay.
Yeah.
So,
So they follow the
let me
research.
clarify something. So the point of the classes that you do is that after the 8 to 12 weeks, based on which class it is, that this is something that they can continue to do at home on their own, as opposed to a typical exercise class that the Y might have.
Like Silver Sneakers.
Which would be something that they would go to, and there would be the cueing of the teacher, and they can follow the teacher, which I think is more appropriate with someone who may have some dementia, because they can follow along, and they can just watch what everybody else is doing. But your classes really are designed to teach them so that they can go and do on their own later.
Correct.
Okay, I think that's a good clarification.
But that's good.
Oh, no, it's fabulous, but if
it's-
somebody can't remember the sequence, going to an actual regular class, like your friend going to the Y on a continual basis, is definitely going to be better, because they can just follow along and not have to remember on their own what the sequence might be.
Right,
Even if
because
it
they get
doesn't.
home, then you don't have the instruction
Yeah, I think that's,
nor the movement.
Mm-hmm.
You know, when you get home, oh, well. And that's really the way that they look at it.
that's the problem of every physical therapist in this country.
Exactly. Oh, we work with so many physical therapists, because it's a perfect follow-up, either, you know, to occur concurrently with the ending part of physical therapy sessions, or to follow up after that. Sometimes the value in exercise is simply in doing it. I think of that from the Silver Sneaker classes I teach. You're there and you do it. I mean, you can think about lifting weights, but when you're lifting weights, I mean, that's when the real advantage is. So, but I know exactly what you're saying as well. That's why both programs have a guide after the program is over. The Matter of Balance program, we give each person a manual. And there are 9 sections, one for each of the 8 classes, plus one for the exercises. And those are shown in words, explained in words, and most of them are shown in pictures. And so you can go through that book, just flip through and do them, and we can tell people you can split and do 10 minutes in the morning and 10 minutes in the afternoon, and it still greatly, it allows them to continue the improvements they have made during the class. If people never do them again, then much of that is lost. But people that are serious about it will use that book or that DVD in the other program to
Stay in
continue.
class. What is the average age of the participants, and what is the recommended age to take the class?
We run into people under 60 who need it, and we allow them to take it, but then they pay for it because our funds, AAA funds, cannot be used to fund that, of course. And people are willing to pay for it. $85 for Matter Balance and $45 for Moving for Better Balance. The reason Moving for Better Balance, it's a longer program, but why does it cost less? There's only 12 in a class, and we can take up to 25 in the other program.
So if it's a prevention class, then people age 60 should get a spot there, but your usual participants are
60s and 70s. Generally, I would, just off the top of my head, I would say 65 to 80 is our main group.
So people that have the, who are going to be falling are usually in their 70s, 80s?
That is a really individual thing as well, as other people were saying this morning. I mean, people that have a history of falling and they're much younger. I mean, there's so many factors. Being, emotionally distressed, being exhausted, not feeling well, having a new medication, having some kind of a neurological issue to where the communication is compromised from the brain to the process of telling the muscles what to do. So, I mean, I can talk about averages, but, it's really there's no one that has never fallen. It's just normal for babies and children. Maybe not everyone has fallen as an adult, but it's generally very, very common. And many times it doesn't end in serious injuries, but it's enough to get someone's attention, like, okay, I'm sort of okay right now, but boy, in a couple of years, I'm not so sure, or 5 years down the road, or someone in their family has a serious fall and injury, and it can be a friend. We can be traumatized by someone close to us going through.
This is a prevention program instead of
They are.
after the fact program.
I would say both. I really would say both. I mean, they're explained as fall prevention. That's what they are. But it's to address the medical issue, the health issue of falling, which occurs not because we are aging, but as we age, it's more common. That's one of the myths we talk about. There's one statement in an attitude-related fall survey in Class 2 that the first statement is basically, I need to accept the fact that I'll be falling more because I am getting older. And it creates a lot of discussion. So not everyone who ages increases their number of falls or even have falls related to someone else who does. So that's what I mean when it's so individual.
They say that because you don't pick your feet up like you used to, then they get tangled up in things that you should not.
That would be one more factor. We do a pre and post balance assessment, by the way, in the Moving for Better Balance program. It takes 3 or 4 minutes, and there are 3 things we ask people to do, and one is the tug test, which is highly recognized as an indicator of falls. And the person sits all the way back in the chair. Arms can be wherever they want. We time them on a stopwatch. They stand up, walk 10 feet, which we have marked floor. They circle around the mark on the floor, the tape or whatever, turn around, come back, turn around again, sit down in the chair and lean back. Sounds very simple, right? But depending on how many seconds it takes a person to do that, that's a well-known predictor.
Does age have anything to do with it?
Does what?
Age have anything to do with it?
Oh, just a person's ability and coordination and how fast they're used to moving. If someone has exercised routinely, then it generally it affects that positively, as you would expect. The greatest increase in numbers that I've seen personally, someone taking the pre-post test for the Moving for Better Balance program was a man in Teller County with Parkinson's. He and his wife were in my silver sneaker classes up there few years ago, and she didn't have any particular issues at the time, but he did, and mainly because of the Parkinson's. And another test we do is, hands on the shoulders, and you stand all the way up and sit all the way down. He improved more on that single test than anyone I've ever had in the years of classes that I teach. So it was amazing. I mean, way more than he almost tripled. So part of it in both programs, it's knowledge about what makes us fall. It's knowledge about ourselves, what our risk factors are, what our habits are, our attitudes, thinking patterns, that sort of thing. But it's also confidence levels. And sometimes when we have more information, if we know the importance of picking our feet up to prevent falls, then we're probably not going to end up being a shuffler, hopefully not down the road. So part of it is confidence and knowledge. And someone mentioned the social group, too. That's a huge part of the programs. People pair up and become exercise buddies. We encourage that highly. So.
Becca, I noticed that one of the challenges that you've got listed is participation and attendance in the Matter of Balance class. Is there anything we can do to assist in that regard?
Not that I can think of, and I'm always trying to brainstorm that too. I would say at least 8 times out of 10, when someone drops or they're unable to continue coming to the sequence of classes, it's because of health issues, either their own or their spouse or someone they're taking care of. It's, well, we didn't know the surgery was going to be in March. We thought it was April, so we're not going to be able to finish the class. So,
Is it possible to partner with primary care physicians? We're working with a similar program for Healthy Heart Initiative at the Jetwing location.
okay, at Southeast? Okay,
So if
we're
you
always
had
open.
contact with the primary care physician and their care coordinator,
Mhm.
you may be able to keep them engaged through that, or be able to understand that there is a procedure coming forward,
Okay.
and when the time to recommend that class would be to gain more attendance.
Well, a lot of time, and I use surgery as an example because that does come up sometimes, but many times it's something just that has just happened, not something that's pending, but that, yeah. And I did list, I'm excited about this. We have been, let's see, I think I'll list that. One of our new, I trained some new coaches last year for Matter of Balance, including Nancy Stannard, who I didn't know until last fall. I met her and, of course, fell in love with her. And she's wonderful. And so I did a training last fall and ended up with 4 new Matter of Balance coaches, and 3 of them are in Teller County. I know. I keep training people, and then lives change, and then I lose them. So it's been a struggle, and now we have a wealth. At the Woodland Park Senior Center, the Pikes Peak Regional Hospital, Florissant Library. I've done them at Woodland Fitness because I taught up there 7 or 8 years. And the Methodist, is it Mountain View? Methodist Church, okay, yeah. But we're looking for new locations, so if you have any ideas, let me know. Yeah. So anyway, one of the new coaches, the one that lives in Colorado Springs, teaches a lot of senior classes, and she is a physical therapy assistant. And so one of the doctors that she's connected with has asked us to teach a class at Penrose St. Francis Primary Care Building. So we'll be doing that as soon as Christina is able to schedule that.
Where would somebody go to find out where a class is?
The YMCA website, we use a lot of ways to advertise. We haven't advertised through the Gazette because we realize we would be just overwhelmed, possibly. So there have been extensive articles in Life After 50. In fact, a lady who used to write a lot of their editorials attended a series of the classes and chronicled it in like 3 months of Life After 50. I don't know if you all saw that. It was a couple years ago. That class was at Grace St. Stephen's Episcopal Church. So, and then I'm trying to think of other local publications.
Comments or questions? Yes, Lisa.
When not this year, but last year, when Candace was doing our evaluation, we came and observed the Matter of Balance class.
Oh, okay.
And one of the things that we really enjoyed was actually participating in some of the exercises. I'm wondering if you would get us a little bit out of our comfort zone and maybe do just 1 or 2 Matter of Balance exercises.
Oh, I'd love it. Turn on the music. No, I'm kidding. We don't need music. We don't use music. Sure. Does anybody want to do that?
Sure.
Only if you want to.
Why not?
Stand on 1 foot.
Yes, I remember you took it, and I know Norma's taken it. Yeah. Norma did, and Nancy has, and Nancy now has helped teach one. Francis took it. So, okay. Let's see. Because of distance between chairs, I'm wondering, do you have room to turn sideways to your chair? Let's put our left hand on whatever chair is in front of you. Or how about right? You all probably would rather look this way. Yeah, look at my back. I don't know. All right. So if we have our right hand on the chair, we're going to think about our center of gravity is right behind the belly button. So for Matter of Balance, let's think about taking, it doesn't really matter which way you're facing. So let's slide the left foot, if your right hand is holding onto the chair, and just make a little circle out to the side and bring the left heel in front of the right toe. So that heel is touching the toe. Then I would like you to slightly shift your weight forward so your weight is sinking into both feet. Oh, dear. I know.
And I'm sitting.
And I'm sitting. I love it. Okay. So we always tell people you can hold, you can have your hand on your chair, because we don't want anybody to do anything that feels, too risky. But then is graduated how much support you're going to use. Then if you're white knuckle, then just loosen your grip, or maybe go to a finger on the chair. The next level would be hovering, so you can reach that chair quicker than you can blink an eye. Or the next goal would be then not to have your hands on the chair at all. And so we would do that. The book shows us taking the foot forward. It's called leg slide to the side. They've got funny names. I also like to have groups take that foot to the back and shift their weight a little bit to the back. For some people, it's about 50-50. It's a lot easier going to the back. The other half of the group says it's a lot easier going to the front. And, of course, we do both sides. So, and if it's too easy for you, you can always get in position, sink your weight. You always want to kind of use your ab muscles, and then close your eyes. That would be the next level. Trust me, in physical therapy, that's when it gets really challenging.
Good thing you're not going for a drunk driving test.
Well, that joke always comes up. You'll be prepared.
Because I know I've seen it.
That does sound like Phyllis. Yeah. Okay.
Funny that
she went there.
Yeah.
Just wonder if she's had that. Just keep it.
All right. And then in moving for better balance, I'm trying to think of one you can just do right in front of your chair. We'll just do a very, very easy one. So let's just balance and sink our weight into the right leg. Step the left heel out a little bit in front of you and a little bit diagonal. So you're going to put your heel down first, putting your weight on your heel, then sinking your weight into that leg. Now where's your center of gravity? It's between your feet. So this automatically is a riskier position. But we take it a little bit farther. We're here, we shift that weight forward, find your balance. Then we're going to shift our weight up by lifting the back heel. So sometimes I get this, and if we get this, it's that we're trying to keep that center of gravity in the safest place, but we don't want to. We take it with us. Lift. When you find your balance, and in the program you would have your arms up in the air. We won't do that. And then it's to try to lift that back foot just for a moment. Lift and lower.
That was windy.
Then we're going to sink that back heel, shift our weight to the back, pick up the foot and bring it back. So, thank you.
Thank you very much.
Okay.
Very, very useful.
Thank you.
Both the words and the exercises.
Didn't realize I was kind of They think I'm kidding about that DUI thing. They're wrong.
No, I think no one thinks.
Maybe we should consider doing that each meeting. Tai Chi, yeah, hands up and, all that, okay. Well, the next item we have on the agenda is the director's report.
Great. Thank you. It's been a busy month. I'll try to be brief. Wanted to let you know that last week there was a joint meeting between the Commission on Aging and the C4A, which is the Area Agency on Aging Directors for the state. Very productive meeting. We got to meet the new chair of the SAPCA group, a woman by the name of Karen Brown, and then we also got to meet Wade Buchanan, who is the new senior advisor to the governor. Has just been appointed. Eminently qualified gentleman. He was a policy advisor to Governor Romer for a period of time. He has run 2 different departments within the state, and for the last 15 years he's been the executive director of the Bell Policy Institute, which I think a lot of you are familiar with Bell. They do a lot of work in terms of protecting seniors and vulnerable adults in the state. So bright guy. He's a CC grad and a Rhodes Scholar. So I think we got a good person in that position, and we have the voice of the governor, or excuse me, the ear of the governor, which is important. Also out of that came the fact that a legislative caucus has been put together for specific aging issues. Their first meeting is tomorrow, I believe. So we have contacted, or I have contacted a couple of our local legislators, but if you know legislators personally, and I would encourage them to be involved with that. I've got that information if you need to know that. We continue to work with Innovations in Aging on the senior portal. We had a meeting yesterday, and we're kind of making progress on that. The senior portal has evolved to what we call a splash page. In other words, as many of you know, we provide a lot of services. We have an information and an assistance desk that's very informed, does a great job. We get a ton of calls. Silver Key gets a ton of calls. What we don't, what neither of us do a great deal of is marketing and advertising on how to get to those points. So a splash page would allow us to go out and actively market to folks and say, if you want to know anything about senior issues, go to this point and it'll get you to the right place. A lot of those calls are going to come to us, but we've also included areas that may not have already been in that sphere. Cultural events, you know, what types of things seniors might be interested in. Health and safety, which we do a little bit of, but not nearly enough. So we've expanded that sphere just a little bit, and hopefully that will launch sometime in the next few months. Money. Did anybody hear me last month?
Yes.
Okay, it's the same.
Loud and clear.
Would you just like to read the minutes from last month?
I know people around here are tired of hearing my analogies, but this is analogous to going to a restaurant, ordering a meal, sitting down, having people bring it to you one bite at a time, and then they bring the dessert and say, we close in 1 minute. So we are getting small bits and pieces through these continuing resolutions. We have not gotten enough to get our final federal allocation. When that number gets big enough to tip the scale to make it worth the state making that allocation, we will get it, and it will most likely include carryover money from last year, so almost a year-old money, and then whatever's left of the federal part, which in some cases, in some programs, that's up to 35% of the annual budget. So it's been a real guessing game. I'm not going to speculate on what's going to happen. We are fairly certain we're going to get all our money. We just hope we get it in time to be able to spend it. Our new executive director, yes, Mrs. Ellis. Sure.
Peggy was talking about the carryover money wouldn't need to be spent until November?
This is the part where I'm not on the record. We anticipate that we are going to be able to, and I think to start off with, I think Peggy may have been using a different context to define carryover. Carryover in our traditional sense, what this group knows carryover as, is the money that is left over at the end of the year that you get to spend the next year. And what she was really telling you is the original purpose for carryover money, which is to bridge that difference between a federal fiscal year and a state fiscal year. It doesn't bridge very well when you don't get it until October, and it's supposed to bridge from July to October. Carryover money will most likely be included in that batch, and most likely will not have a 10% cap restriction on it. So I know that's a relief to a lot of you, because if it had a 10% cap restriction this year, we'd be in big trouble, because we would lose a good portion of it, or we'd be spending irresponsibly in the month of June. And that's our goal. We don't want to spend money poorly. We want to make sure that it's put out and used in the best fashion possible. And the scenario right now, if you're a speculative person, which some of us are, is that we're going to be a little thin going through April, May, June, but we're probably going to be in really good shape next year. So, and I think I mentioned last month that the governor, in addition to try to ameliorate some of these issues, has put some extra money into his budget, which may come to us next year. So we're not supposed to live in a feast and famine environment, but that's kind of the way it's been for the last couple of years. I get a new boss in a month, which we're really excited about. Andy Gunning has been appointed the new executive director. He will start February 20th. and that does get him here in time to be at our next RAC meeting and see the provider fair, and so we're really excited about that. As many of you know, that was a fairly grueling process. It took, when it's all said and done, it will have been about a 14-month process to get somebody in place. And the good part is I think we've got a really good person. I was privileged to be on that team, and I can tell you that we had to restart in there. We did a full set of interviews, didn't pan out the way we wanted. We started a second set of interviews. I can tell you that everybody in that second set of interviews was better than the people we talked to in the first set of interviews. So it ended up being a fortunate thing for us. So we're going to be happy when he gets here. And
Where is he coming from?
he's coming from Rockville, Maryland, which is a D.C. suburb. I know there's some folks who are very familiar with Rockville, Maryland. It is right in the heart of the bureaucratic center of the United States, and so he knows that side of things very, very well. So we're excited to have him. He is currently the acting director of the MPO, the Metropolitan Planning Agency there, and he has history working with a COG. The COG in Tucson, I believe, is where he was before. So good experience, and he's got a good attitude. You know, he's seems to be a real humble guy and wants to learn a lot about what we do here. The Convention and Visitors Bureau has elicited our support, the AAA support, but also will most likely soon be asking for volunteers who are seniors in the community. They're doing what they call their destination master plan. So in other words, how do they make Colorado Springs be an appealing place for seniors to visit? And we're going to do some focus groups coming up. So there's a good possibility that I might be giving you a call at some point. If you're interested in being involved in one of those focus groups and telling people why you think Colorado Springs would be good, let me know and I'll put you on the list. Senior Day at the Capitol is coming up in March. They've established the date. I have a flyer, but we can also email that out to you, too. So I'll ask Carrie if she can get that out.
Actually, hang on. There we go. It's on my list of things I'm going to send an electronic copy.
Oh, super. It's set for March 21st. It's always on Wednesday, as you know, and this is going to be a really busy year. SAPCA has completed their work and is making several recommendations to come forward. So the legislature, as we speak, the legislature is looking at a lot of things. But Senior Day at the Capitol allows, if you haven't been there, I know Dave's been there, and there's been people in this room that have been there. It's a great opportunity to see how the COGS work. And then last thing, SAPCA, I mentioned earlier, is continuing its work. They earlier in the year they did a what they call a listening tour, where they went around to different places in the state to kind of see what folks were thinking about what they should be working hardest on. They've issued a report called Conversations on Aging. Can we send that link out too?
Yep.
Carrie?
You bet.
It's a comprehensive report. I don't think there's anything extremely new in it, but it's a really good synopsis of what people in the communities were telling them. I know Carrie had an opportunity to go to a session. I had an opportunity to go to a session, and it's good to see somebody from the state coming around to listen to you instead of tell you something sometimes. Any questions for me?
I think one of the things that SAPCA had done, they made a recommendation, I think, for a senior executive to be positioned at the governor's office. Has that occurred? And what's
That's
the
Wade
impact of it?
Buchanan that I was just
Okay,
speaking
that's
about a
Wade
minute ago.
Buchanan.
Yeah, the technical title is Senior Aging Advisor to the Governor.
Okay.
And he is part of the governor's cabinet, so it's a direct link, and that's a huge step, quite frankly. That was their number one recommendation, and they have already accomplished that. So we're happy to hear that. And you've got somebody who's qualified, not only qualified, but also knows the senior side of the business, has worked in that area.
What was his name?
Wade Buchanan. It's Buchanan. You can Google him and get all the information. As I said, he was he was the director of Bell Policy for 15 years, which Bell Policy Institute has a lot to do with why seniors and vulnerable adults are in the place they are right now in the state of Colorado.
We had a presentation by them when we were in Bailey, and was at that one time.
Yes.
Someone from their organization gave us a presentation.
From SAPCA or from?
No, Bell Policy
from Bell
Center.
Policy, yes.
Yeah, we did
Right.
have Bell come up there.
That's what that was, so.
Right, that was, I'm trying to think of her name. Yes, correct.
Any questions for the director? Thank you very much. So I don't really have a whole lot to say here. I guess I would just piggyback on, emphasize that the Senior Day in the Capitol really is an interesting and I think very enlightening experience. You get a real chance to see sort of a broader perspective on the providers, and you also get a real good insight into some of the legislators and their emphasis and their participation in support for seniors. So I'd really encourage each and every one of us to at least consider doing that. It's really a worthwhile thing. Then the other thing from a more personal note, I think we all, as we get older, we all come across individuals that, life's journey, it has to end at some point in time. So I just was at a funeral or memorial service just the other day, and this one gentleman is the one that got me first involved with seniors 9 years ago. There was an ad in the local paper, and it said, here's what this organization up in the Monument Tri-Lakes area is doing. If you have any questions, comments, contact Chuck. I had coffee with Chuck, and Chuck is the one that now, he just passed away. But the interesting thing that I wanted to throw out is that I think we've all come across in our work lives or volunteer lives, family lives, whatever, that one individual, that unique individual that has had such a passion, a mission, a focus, a drive to accomplish things. And in the case of this individual, he really has been instrumental in making a huge difference up in the Tri-Lake Monument area. Back in 2006, 2007, he was just driving ahead. And come to find out in the memorial service yesterday, he was a Apollo project manager. Who knew that in a tiny little town of Monument? But I'm just mentioning that because I think all too often we talk about organizations and the impact the organization has on this particular constituency or this community, whatever it is. But fundamentally, it's the individuals. And the individuals like you all, both in the attending here as well as the members, we have a huge opportunity, and I think we have a pretty good occasions to take advantage of that and to have an impact in our community for those seniors and those things that really are personal to us. So I just want to throw that one out there. It's more of a commentary from my perspective, but it really hit home that an individual can make a huge difference. And as Teddy Roosevelt's phrase was something about, he or she is in the arena with the dust and the blood and the rest of it. You're in there fighting away, but you're really driving ahead because you are committed. So as we start the new year, I guess I would just kind of say, let's all try to, increase our energy level or our focus or something to try to make a real impact, not only here, but in our own communities. Any other thoughts or comments? I'm looking at the agenda here. Carrie, you have some things to talk to us about.
I do. So I will not tell you about Senior Day at the Capitol because that was on my list and everybody else has gotten it. I want to remind everybody, we had a 1-hour delay on Monday morning. Had we had a 1-hour delay on the day of the RAC meeting, the office would have opened just in time for people to walk in at 9 o'clock. But sometimes we have 2-hour delays. Hopefully we will have many before the end of the year, which are an indication that there's snow and moisture. But it doesn't look like that's going to happen. Just remember that we have an inclement weather policy, which you received in your RAC packets when you joined, and more importantly, just call the main number. We will have a message on the outgoing, there will be an update to the outgoing message by 6 o'clock in the morning, well before even, I think, Bobby and Carmela have to leave Park County to get here. So if we have a 1-hour delay, the meeting will, of course, start at 9 o'clock. But if we have a 2-hour delay, we will figure that out at the time. Don't expect the doors to open before 10 o'clock. 471-7080. and that gives you the outgoing message, which will give you the update. Joe wants to piggyback.
I was just going to add one little thing. This is the first time I've ever in my life heard of a 1-hour delay. So it's usually 2. So it's fairly rare.
Correct. We usually have 2-hour delays. I also wanted to give everyone a heads up on a couple of things that have come across my desk in the last week or so. The octogenarian golf tournament is on again for June 18th. It'll be at the Colorado Springs Country Club again, and our former RAC chair, Al Williams, is spearheading that, and I'm sure Joe will be very happy to get dressed up in his golf clothes and go out and staff the table again this year. It's a great opportunity to be outside on a lovely summer day. The Manitou Springs Health Fair will be coming up in April, so I'll make sure that that gets announced again at the February meeting. And then last but not least, new members, please see me before you leave. I have stuff to give you. There are 3 of you here. Okay. Yep. So more specifically, Jody, Jen, and Joanne, please see me. That's it. Thank you.
Any comments before we consider adjourning? Yes, ma'am.
So I just wanted to put some vibes out there that the Senior Resource Council is looking for nominations for their Joe Henjum Accolade Awards. So they honor volunteers in the community. There's 3 different categories, but there's a business professional, so somebody who works with seniors but yet still goes above and beyond outside of their scope of work to do additional things for seniors. A business, again, who goes above and beyond for seniors, and then an actual senior. So you can get all of that information on their website, which is just srccos.org, Senior Resource Council, Colorado Springs. And the nominations, forms, and all of that stuff are on their website. But they're looking for volunteers to be, what's my word?
Evaluators, judges?
No. They want nominations.
Nominees.
They want people who are doing great things in the community to be recognized, rewarded, all of that stuff. So I think a lot of us in this room probably know a few of those, and go and nominate them, and then maybe they'll win an award. And it's a great, it's at the Mining Exchange on April 11th this year, so I'm sure it'll be a fabulous program for everyone. Should come and attend that as well. But all the information, srccos.org.
That's a nice evening.
Phyllis?
Being out east, I work with a lot of ladies and with material and stuff, and they go and they make throws, lap robes, whatever, for seniors, for the kids at the whatever. I brought an example of what they do, just to let you know. We have different ones that they do make, and I take, and I go to the seniors, if the seniors can have them. That's one thing that I found, that sometimes when you go to where the seniors are, they won't let them have them. No.
Why?
I don't know, because they have to wash them or whatever. But anyway, that's what they are doing for me, so that I can take them and give them to people that need them. But the ladies out there in the quilting area, in the country, are doing this. So just wanted to let you know that we are trying to do something to help seniors. You know, when you get into what they can have, what they can't have, you know, that is getting to be my problem now. So then I thought about helping the kids with cancer, you know, in the hospitals, and give them to them. So if you guys have any suggestions as to, per se, where I might go to do this, I'd appreciate it. Would you? I appreciate it.
All right, thank you.
Thank you.
The veterans.
Yes, ma'am.
Hi, I'm Tricia. Thanks. I'm a guest today. It's good to see some faces that I know. I'm a nurse practitioner at the UCCS Primary Care Clinic. It's part of the health circle at the Lane Center. So we're downstairs from the aging center, and we are taking new patients. So I just wanted to plug that, or let you all know that, and that we're there. So we're not Grandview Hospital. take all insurances, well, several of them, I shouldn't say all, but including Medicaid. Like the Medicaid patient I saw the other day, she said, so many are closed to new patients at this time. So just all of you come from all different areas. If you happen to run into folks looking for a primary care home, we're there. We have a geriatric nurse practitioner, Lori Mattingly. She wasn't able to come with me today. I think she'll go through this.
Trish, can you tell us, so are there 2 NPs?
There's several. Seven.
Seven?
So
Wow.
I'm PRN there, which as needed. We have one full-time one, Angela York. She's family NP certified, also ER NP certified. So she's there Monday through Friday, the business hours. And then there's several other NPs. We're all nurse managed. There's a nurse midwife. I put her on the table. But we're nurse managed.
Is that part of the Peak Vista Clinic in there?
So we share a space, yeah.
You what?
Sorry, we're neighbors.
Oh, so but you're not a part of that?
Separate. But if you know where they're located, we're located right next to them.
Great.
It would be maybe helpful if you could, if there's some brochures or some materials, if you could get that here so we could either put it on the website or at least make it available for the members. I think that would be very helpful.
Norma can put it on our brochure wall.
Oh, perfect, thank you. We're revamping and making some new ones since we've updated mission and whatnot lately, so
Okay.
as soon as we get that, we'll add you to the list, but thank you for
All
mentioning.
right, I think that'd be very helpful. Any other comments? I think it's about that adjournment time, if somebody would like to make a motion.
We adjourn.
I second it.
All those in favor?
Aye.
Stand adjourned.
Thank you.
And the new members that should see Carrie.
See me, please.
Yeah, that Peggy's presentation. That was huge.
Joanne, I'm going to start with you. Would you look for your name
No.
on this sheet?
Exactly. So, I mean, you get it beforehand when you first come in, if you get it reinforced at the community subcommittee, you get it.
I work with them.
Yeah.
Look at the colored cells that are next to your name and make sure that what's there is correct, and then add what you see missing. That's not for distribution, that's for me, so that I know how to reach people.
And then understanding state versus federal.
You all good with your power cord?
Having graphics is a big thing.
We seem to have problems with these microphones. Oh, let me turn
And
off.
it's something you take away and you say, okay, now I remember that. I remember Peggy's presentation. Oh, that's how
until
it
next
goes.
month.
Here's SUA and here's how it ties in.
Oh, I don't